Good morning, I'm Swami Iyer, the last day of SOHO with the CML session. I'm here to introduce Dr. Wang, who was awarded the highest abstract based on the scores that were given by the reviewers, and it's a very, very interesting topic in CML. Dr. Wang, you want to talk a little more about that?
Yeah, sure. So basically, our story is about 3q26 rearrangement. I mean, the 3q26 rearrangement in MDS and AML is very well studied. I mean, associates a very, very poor prognosis. However, the prevalence, the impact of 3q26 rearrangement on TKI response and their impact on survival in CML is not known. I mean, there's only like one very small case series, including 4 cases.
So that's very good because just to give you a background, we are seeing cytogenetic abnormalities in CML, chronic phase, a little more in accelerated phase and more in blast phases.
Right, exactly.
And you have peeled out the data on your patients who have chromosome 3 abnormalities, specifically 3q26.
Right, yes.
And I also understand, congratulations, this was published in Blood just recently.
Right, we published this finding in Blood last month, I think August 1st or 2nd, yes.
So what have you found with the chromosome 3 abnormalities in patients with CML?
Right, it's very interesting. I mean, so like we have 2013 cases. So we found 116 cases has chromosome 3 abnormality. Of 116 cases, half of them, like 58 cases, have 3q26 rearrangement. In this particular group, 58 cases, those patients has very, very poor response to TKI treatment. So 58 patients, only 3 patients achieved complete cytogenetic response. And the response is very transient. All these 3 patients relapse, I mean, in a term of 3 to 12 months. So basically, those patients has 3q26 rearrangement, has no or minimal response to TKI treatment.
It's very important. I guess one of the ways you found this is patients had bone marrows done for on a regular basis in MD Anderson.
Right,
and
right.
all the more reason for practicing physicians to look at trying to do bone marrows when they're not responding to TKI.
That's my point too. And there's some arguments say, well, in CML, we don't need bone marrow biopsy. I mean, I kind of partially agree. If patient respond to TKI treatment very well, patient achieves complete cytogenetic response, molecular response, sure, we don't need bone marrow biopsy. However, if patient has resistant disease, number 1. Number 2, if patient didn't respond to TKI, is that a peculiar circumstance? Number 1, we should do ABL mutation analysis, but equally importantly, I think we should do bone marrow biopsy. Yeah, for clonal evolution, do conventional cytogenetics, because by doing FISH, by doing molecular, you can't figure out the clonal evolution.
So could you tell us a little bit more about the 3q26? What is peculiar? Obviously, we're talking about driver mutations, and Philadelphia chromosome is the epitome of CML, but here you're seeing another process happening.
Right, I think the 3q26 rearrangement, which causes EVI1 overexpression, basically provide a BCR-able independent growth pathway in those CML patients. That's one reason why TKI inhibitor didn't work. I mean, EVI1 as an oncogenic transcription factor is very, very powerful to induce leukemogenesis in animal model. So again, I think in this particular patient, TKI is not enough. We have to think about something else, either EVI1 target therapy, which we don't have right now. Yeah, but in our study, we do have 2 patients who underwent stem cell transplant. It's allogeneic stem cell transplant, achieved complete remission 2 years and 7 years after 3q26 rearrangement. So I think so far right now, the only way to treat or potentially cure this kind of patient is transplant.
What happened to the other 56 patients on your study who had
So we have different follow-up time. I think the median follow-up are like 13 months. So only 2 patients at remission, all others either died or has persistent disease.
Excellent, and congratulations on the work. I understand there's a lot more work to be unraveled.
Right. I mean, I think another important point of our studies here. So a lot of literature, including Leukemia.net, right? They include major root change. Major root means trisomy 8, extra copy Philadelphia chromosome, isochromosome 17, and trisomy 19. They include these 4 major root change as a criteria for accelerated phase. They said, well, okay, this is important. Those minor root are not.
So in addition to trisomy 8 and other chromosomal changes, I think you are advocating 3q26 to be also a reason to do other things.
Yes, exactly. I think emergence of 3q26 rearrangement should be regarded as one of the criteria for accelerated phase. And we do compare 3q26 survival compared to trisomy 8, which is a major root change. 3q26 carry a much worse survival than trisomy 8.
Excellent. So thank you once again. I think this is a very good presentation, and I think we all, those who are seeing CML patients, importance of bone marrow and looking for this abnormality, and hopefully we'll have some way to target them in the future. Yeah. Thank you, Dr. Wang.
Sure. Thank you.